day. My name is Dr. Ian Johnston. I'm a pediatrician at the Chatham-Kent Child and Adolescent Clinic. Today, I'd like to continue our series of talks that we have entitled ADHD, a Toolkit for Families. This will be the first of two lectures in which we discuss some of the treatment options for managing ADHD. Before even beginning, I think that it's reasonable to acknowledge that this is a difficult topic. There are many negative stereotypes out there regarding the effect of medications on children. Everyone has a strong opinion on ADHD, its management, the importance of medication, the origin of the condition, and many parents feel a great deal of guilt when they consider whether to treat their child medically for this condition. I certainly wish that I could get up here and say that all of these concerns are completely unfounded. Unfortunately, that's not the case. This is in fact a difficult condition to treat, and there are significant negative aspects to virtually all of the treatment options that I will discuss. That does not mean that treatment is impossible, and it does not mean that many children do not benefit from treatment. Let's start with a few basics. ADHD is a chronic condition. I think of it the same way as I do many other chronic conditions, such as diabetes or eczema. It is a condition that cannot be cured, but the symptoms can be managed and diminished with appropriate therapy. Although symptoms may diminish with time and maturity, a significant number of adults continue to show signs of this condition. So what treatment options are available? Although it's rarely attained, there's relatively good agreement about what would entail an ideal treatment regimen for ADHD. It generally involves some type of parent training, preferably one that is evidence-based. It generally involves some classroom management strategies. It often involves medication, and it may involve some type of talking or cognitive therapy for the patient. Let's look at each of these in turn. There are a number of parent training programs that are available, and several of them have reasonably good research backing suggesting that they are effective. The most popular one in this area has been the P parenting program, although there are a number of others, including the Incredible Years and a list of lesser known programs. Unfortunately, in this area, the P program is available only through the Chatham-Kent Children's Treatment Center, and that is only available to clients of the center. It was formerly available through the Early Years Center, but this has not been available over the past year or so. Parent training programs are frequently available through either the Early Years centers or through the local public health unit. Unfortunately, we're short of this in Chatham-Kent at present. Chatham-Kent Children's Services does provide assistance with parenting, although to my knowledge they are not currently running evidence-based groups for parenting. Moving on to the schools, both local school boards are quite involved in behavior management programs. There does appear to be some variability between different schools. Some schools are very active while others are less so. Contrary to popular belief, formal diagnosis is not required in order to access services through the school. I'm frequently asked for a diagnosis to be written down on a piece of paper so that the student can, open quotes, get help, close quotes. The pediatricians have had extensive discussions with both school boards, and they assure us on all occasions that no medical diagnosis is required to obtain help in either major school board in this area. Needless to say, resources in the schools are spread extremely thinly, and in virtually all cases less help is available than either the school or the family would ideally hope for. This brings us around to psychologically based or open quotes talking close quotes therapy that is directed at the patient themselves. A number of different programs have been described. Generally they involve some form of cognitive behavioral therapy or some type of social skills training. Although talking therapy is certainly extremely appealing, There are a number of problems with this. First of all, cognitive behavioral therapists who deal specifically with the pediatric patient are few and far between in this area and in most other areas. Secondly, the evidence that these interventions are effective is really less robust than one would expect. Understandably, parents and families are often quite frustrated that more resources are not available either at the school or outside of the school. The feeling is that if only a bit more help was available, then unpleasant interventions such as medication could be avoided. While this may be true in some cases, I generally refer to a relatively large study that was performed back in the late 1990s. This was carried out when the first of the long-acting methylphenidate products was being developed. The so-called MTA trial was completed in California, and it looked at several hundred children who were treated with a variety of different modalities. Some of them were treated with intensive behavior therapy alone, and this was really very intense, much more than we could ever expect in our current environment. The children received individual therapy, there was help provided at the school, there was parenting coaching provided. It was really quite an extensive program. In contrast to this, there was a group of children who received only medication, and a third group of children received a combination of intensive behavior therapy as well as medication. A fourth group received just usual care in the community. I've posted the summary slide from that paper on the next slide. It's difficult to see, but for those who are interested, I'll post the slide on our website as well. Essentially what it showed was that, especially in the school setting, there was very little to choose between a medication alone versus medication plus intensive behavior therapy. And the efficacy of behavior therapy alone was significantly lower than either medication alone or combined therapy. Things were a bit more optimistic when looking at the home front, particularly with social interactions with parents. Psychological interventions did seem to be helpful, but even in this setting, the combined therapy and medication alone was superior. Although I sometimes feel like a bit of a no-goodnik when I say it, the unfortunate truth of the matter is that even the most intensive behavioral interventions have a significantly less robust effect size than does medication. We all feel that if we just tried a bit harder, that we could manage without medication. I think that the evidence suggests otherwise in many cases. Let's move on to a discussion of the medication options with ADHD. In this lecture, I'm going to focus just on stimulants, and in the following lecture, we'll look at the various non-stimulant options. The drugs of choice for ADHD are generally considered to be stimulants. These are the devil we know. It's impossible to do a trial now about whether they're effective. There are over 100 trials out there showing benefit when it comes to behavior, academic performance, teacher satisfaction, and even family satisfaction when stimulants are used. This is not to suggest that they're helpful for everyone. Indeed, they are not helpful for all patients, and side effects are an ongoing problem with these medications. A quick primer on stimulants. Although there are many different names around, especially in the United States, but even here in Canada these days, in fact, there are just two different families of stimulants, and both families come in long-acting forms and short-acting forms. The two families are the methylphenidate-based. This is based on the old Ritalin. The long-acting forms are bifentin and Concerta. Precisely the same molecule is present in all of these medications. The second family is amphetamine-based. The original one was Dexedrine, and the long-acting forms are currently Adderall and Vyvanse. The two long-acting forms are slightly different chemically than dexedrine, but are in fact very similar. There's no compelling reason to choose one family over the other. Neither is better or worse, stronger or weaker, milder or less so. Some people simply respond better to one family. Some people respond better to the other. Although we would all like to predict ahead of time who would fit best with a given family, none of us have been able to come up with an algorithm that will allow us to do so. It ends up being a matter of trial and error. Many characteristics are common among all of the stimulants. The side effect profile of all of them is essentially the same, although people are affected in greater or lesser degrees by different drugs. All of them are relatively quick in their onset. These are not medications that require time to build up in your system. If you take it today, you will have an effect today. And if you do not take it tomorrow, there'll be virtually no residual effect from the day before. Every day is a day unto itself. Short-acting medications such as Ritalin and dexedrine last 3 or 4 hours. Long-acting medications last anywhere from 8 to 12 hours. There's some suggestion that Vyvanse lasts a little bit longer than the other two, although the differences are relatively modest. Although most studies fail to show a significant difference between long and short-acting preparations when it comes to efficacy on standardized questionnaires. If one looks at patient and parent satisfaction, the long-acting medications generally come out on top and are certainly the preferred medications in my practice. Unfortunately, the short-acting medications are significantly less expensive than are the long-acting ones. The way it works with Ontario Drug Benefit is that they insist that one tries short-acting stimulants first. After that, one can switch to a long-acting preparation with no further documentation. Most third-party plans cover long-acting stimulants from the outset. Given that there is little to choose between the medications from an efficacy point of view, one often ends up making a decision regarding which medicine to start based on more practical matters. Short-acting stimulants such as Ritalin and dexedrine can be crushed and mixed with whatever you want. I'm told it doesn't taste particularly good. Concerta, on the other hand, cannot be crushed or broken. The time release is actually in the capsule, so these medications have to be swallowed whole, which is a consideration for younger children who may have trouble swallowing. On the other hand, Adderall as well as bifentin can both be opened. They have microbeads inside, and these beads, although not dissolvable, can be mixed into a yogurt or applesauce, and are sometimes easier to take for the younger child. Vyvanse, on the other hand, can actually be dissolved in a liquid and taken in that way. Interestingly, Vyvanse is only active once it is metabolized in the body. That's the way the time release works in this medication. The corollary of this is that there's no quick onset, so there's very little potential for abuse in Vyvanse, which is a consideration in teenagers and some other populations. What is it that stimulants do? They're effective in ameliorating all of the core symptoms of ADHD. That is, they're helpful for hyperactivity, for inattentiveness, and for impulsivity. It seems paradoxical that a stimulant, which is an upper, can actually calm someone down. How does it work? Like almost everything involving the brain, the exact mechanism of action isn't fully understood. It does appear that it affects the amount of dopamine that's available in the frontal lobes of the brain, and it's hypothesized that it is through this mechanism that the stimulants affect behavior. An alternative way of looking at it is to consider ADHD as a failure of inhibition. This is one of the major theories of ADHD. The problem with ADHD individuals being that they have difficulty inhibiting. They can't stop, they can't attend to things, they can't consider alternatives and make appropriate decisions. They see and they react. There's very little between stimulus and reaction. One can think of stimulants as increasing the ability to inhibit. and thus resulting in the paradoxical reaction of a stimulating agent actually slowing someone down. This is a somewhat anthropomorphic way of looking at it, but in a way it's more satisfying to a simple mind such as my own. Moving on. Assuming that one has the correct diagnosis, what is the likelihood that a given stimulant will be helpful for an individual patient? If one tries one agent, one stimulant, it doesn't really matter which one, about 70 to 80% of children will benefit from a core ADHD symptom point of view. If one trials a number of different stimulants, one will eventually find something that's effective in perhaps 85% of patients. For reasons which are unclear, at least 10 to 15% of patients do not respond to stimulants, even when the diagnosis is quite clear. Unfortunately, virtually everyone has side effects. I tell all my patients that they will have side effects. I tell them that there's the big three and that there's everything else. The big three are, first, appetite. This is hardly a side effect. This is an effect of the medications. Stimulants are very effective appetite suppressants. Second is sleep disturbance. And third is irritability. Let's go through these in turn. As I said, appetite suppression is very close to universal. Most of the children find that they're not as hungry at lunch when the medication is most active. I encourage them to eat a good breakfast, and as long as their appetite has returned by supper time, generally they're all right. They make up for it at the end of the day. Many of them are quite hungry when they come home from school. On the other hand, those children who are particularly sensitive may be not hungry for lunch and for dinner, and then weight loss becomes a concern. And it's not rare to have to stop medication or cut down medication due to concerns around weight loss. Second is sleep. This is again particularly the case when using the long-acting medications. Sometimes it's mild. The children go to sleep at 8:30 instead of 8, which isn't a particularly big deal. On the other hand, some children are quite sensitive, and they find at 11 o'clock and 12 o'clock and beyond, they just can't close their little eyes. And it's really very difficult, and it's not rare again to have to stop or institute some other type of therapy due to sleep disruption. Irritability is the most difficult one. It's particularly a problem in the younger children. I always tell kindergarten children and parents that the better part of half of patients who start on stimulants end up having them discontinued due to side effects. Irritability can manifest itself as either rage, or it can show itself as being very emotional. The children become very tearful. Parents are quite shocked when I say that this can be a side effect, because most children are less irritable. They don't get as angry. They don't get as upset as they did in an untreated state. There's a significant minority, however, who go the other way, particularly those who aren't responding particularly well to the medication. Very often, the irritability is just at the end of the day as the medication is wearing off, but sometimes we see it all day long. And I must say that my biggest disasters, the children who don't make it past a few days on treatment, are generally those who become extremely emotional or angry with treatment. After the big three comes the one that one reads about frequently in the newspaper or hears about on the radio, is the so-called zombie effect. These are the children who are over-flattened. These are kids who go from being inattentive and trying to focus on everything all at once to children who have lost their zest for life. They seem to be uninterested in things around them. I always say they look as though they have the blinkers on. They often come in looking a little bit sad. The older children who are more verbal will often say that they feel a little bit down. And obviously this is extremely distressing for parents. And I always consider this to be a very unacceptable side effect. I always tell parents that the reason we treat is not to make the teacher happy, and it's not even to make the parents happy. It's to make things better and easier for the child. and if one is just flattened out and unhappy, that isn't better, that's worse. So when we see this, which is not common but not rare, we really have to do something else. We have to try a different medication, we have to cut down the dose, or we have to stop altogether. Unfortunately, the list goes on. As will be discussed in another lecture, anxiety is frequently seen in conjunction with ADHD. Stimulants and anxiety can be a difficult combination. Stimulants can really exacerbate anxiety in a child who also suffers from this condition. Similarly, tics can sometimes be made worse by stimulants, although by no means is this always the case. Tics are not a contraindication to stimulants. Sometimes, in fact, they seem a bit better when you start them on treatment, but it's not rare to find tics become significantly worse with stimulants. Growth is an issue that comes up frequently. It is true that there is a small but measurable decrease in height velocity when a child is started on stimulants. This appears to be most marked in the first year or so, when there's about 0.5 to 1 centimeter average decrease in growth than one would have expected otherwise. It's unclear whether there's catch-up growth as time goes by. So I generally tell parents that I can't guarantee them that treatment won't cost a centimeter or so in eventual height. And this is something that just has to be taken into consideration when one is deciding whether to proceed with medication or not. Finally, if one looks on the internet, one will see that there are concerns about cardiovascular effects of stimulants. This has been an area of controversy of late. The American Cardiology Association at one point recently suggested that children have an ECG prior to starting stimulants. The American Pediatric Association felt that this was ridiculous and did not make such a recommendation. If one looks at the numbers, there's a suggestion that there may be a very small increase in the incidence of cardiovascular events in children on stimulants. This seems to be primarily in children with pre-existing heart conditions, and even at this, the effect is extremely small. In children without pre-existing conditions, the incidence is in the order of 1 in hundreds of thousands, which may or may not be a consideration when one is making a decision about whether to start treatment or not. So what's a reasonable way to proceed? We have a condition which can cause significant impairment, but we have a treatment which can be extremely helpful. And make no mistake about it, stimulants can be life-changing when they work well, but can also have very significant side effects. First of all, it's incumbent upon us to be as sure as possible that we have the right diagnosis. Second, we have to ensure that we are dealing with an individual with significant impairment. And third, we have to see whether the family is willing to consider treatment with medication. If the answer is yes to all of these questions, then it's reasonable to consider a time-limited trial of a stimulant medication. In my practice, generally, I conduct trials over a period of about 4 weeks. Generally, I use a couple of different doses during that period. We try to include standardized questionnaires at several time intervals through the trial period. We have questionnaires filled in by parents and by teachers. At the end of the trial period, we review the questionnaires and review the experience of the family and of the patient. We ask first, was there any benefit? Because there may not have been any. And second, what were the side effects? And almost certainly there will have been some. We then ask the question, was this a fair trade? If the results of the trial were positive and the family is pleased with progress, it's reasonable to simply carry on. On the other hand, if the effect was suboptimal or if the side effects were problematic, then one would consider whether to try a member of the other family of stimulants. Alternatively, dosage adjustment is a possibility. And as always, it's important to reconsider the diagnosis and make sure that the starting point was appropriate. Often we start with short-acting stimulants and then move quickly on to long-acting stimulants. If after trying a number of different agents it becomes clear that the stimulants are not going to be helpful for this individual, then one needs to consider whether either to try a non-stimulant agent or whether to abandon medication altogether. Given that very frequently these patients have quite significant impairments, very often we move on to non-stimulants at that point. This will be the topic of our next lecture. Thank you so much for your time and attention.